Well, welcome everyone to the INAD PLAN Families Clinical Group meeting. My name is Erica Dale. I'm an assistant professor at the University of Florida, but my role here is just simply to moderate and to keep the conversation going if needed. Let you know you're in the right spot. This is a clinical group meeting where families have submitted some questions beforehand, and we have an excellent panel of experts in the area. We've got Allison Gregory, who is a board certified genetic counselor and an assistant professor in molecular and medical genetics at Oregon Health and Science University. We have Dr. Susan Hayflick, a professor of molecular and medical genetics, pediatrics, and neurology, also at Oregon Health and Science University. Dr. Jenny Wilson, an associate professor of pediatric neurology at Dornbecher Children's Hospital, also at OHSU. Dr. Darius Adams, a medical geneticist at Goryev Children's Hospital, also a board certified clinical geneticist. And last but not least, Dr. Paul Kotzbauer, MD, PhD, professor of neurology at Washington University School of Medicine. So they do have some questions that some of you have submitted. I also encourage you to put questions into the chat box. I'll be able to monitor that and feed questions as we go along. So without further ado, I would like to pass it off to Allison Gregory.
Thanks, Erica. I'm hoping I can ask you to stop sharing your screen. I think then all the participants will be able to see us talking. Okay, there we go. And everybody else on the panel has capabilities now to do everything. Okay, so participants, families with PLAN, you all know you submitted questions in advance and we wanted to make sure we address those, and then we should have plenty of time for new ones through the chat. And the reason I say we should have plenty of time for new ones is you didn't submit too many. So I've got a short list. I'm going to try to make sure I direct them to the sort of best person for the job within our panel, and others are more than welcome to join in. Even if I call on somebody first, please just contribute as you like and we can take it from there. You do all have the ability to use the chat as we're talking. So please, if you have a follow-up question to a topic we're already on, just go ahead. I'm going to be watching that chat box as well. So our first question I'm going to direct to Susan and Jenny as a starting point. This was one of the only questions about younger kids with INAD. And the question is, what therapies are standard for INAD and who should be on the care team?
So maybe I can take an initial run at that and Jenny can fill in all the important stuff. So I do want to say at the outset, we have developed a best practice guideline for the care and management of people with PCAN. Jenny led a project to develop such a guideline for BPAN, and she has graciously agreed to lead a project with international collaborators, including some people here, for INAD/PLAN as well. And so that is something that we're going to get to work on, and that will give both your families and your healthcare team taking care of your children some ideas that are generated from sort of consensus expert opinion. So they're not necessarily driven by large studies. We can't have large studies for the most part, but those will help. So in talking about INAD versus, that is the infantile form versus juvenile PLAN, I think there is some difference who should be on the care team. But certainly geneticist and genetic counselor, I think, is critical to understanding the basis of the disease, to serving all of the purposes that those of us in this field serve. And in an ongoing way, I think we can continue to be a resource to the family over time, along with the child neurologist, a set of therapists, an ophthalmologist, so a set of therapists, physical and occupational therapy if they need feeding assistance, if somebody who's got kind of expertise in feeding therapy, an ophthalmologist, maybe on a once or twice a year basis as needed for the eye aspects, And then beyond that, I would say if there are particular challenges for that individual child or the family, that it makes sense to fold in people appropriately to help with the management. So for example, there are developmental pediatricians who are very experienced in taking care of complex kids with who need sort of management A to Z. They need management of their feeding. They need constipation management. It's kind of like they're the one-stop shopping for complex children with special healthcare needs, and that kind of a person can be a really good primary healthcare provider for the individual with PLAN. And they'll know the resources for pulling in experts for pulmonary care, for help with sleep management, those kinds of things. So Jenny, you have things to add there?
That was really comprehensive. I guess the only other addition would be speech or communication specialists probably for most kids, even if they don't have spoken words. There are other ways to work on communication, and there's no child who you would just say would not benefit from such therapy.
Okay, thanks, Jenny. Anybody else want to add anything before we move on? Okay. I'm going to dive into the genetics stuff because we had two really good genetics questions and we've got two really good geneticists here. So maybe Susan and Darius can address these together. The first question was, will gene therapy be available for my children? How far away are we? And there is a completely separate research update that will address this in fine detail, but because we have extra time here and because it's a slightly different question, I thought maybe we could address it.
Well, I guess I could chat a little bit about that. I think really we're at the stage where we're looking at animal models for this, and certainly a lot of basic science work still needs to be done. Paul can certainly jump in on this as we're talking about that, because this is an area that he's been working on and involved with. I think it's a hope. We're all sort of going in that direction. PLA2G6 is monogenic, right? INAD is monogenic. And so it certainly would be a good candidate for gene addition therapy versus something like CRISPR, which is also a possibility where it could go in and change mutations directly. But we'll probably be in a better position to do gene addition therapy initially. But with all of that, we need to get the animal models done and see how those turn out. And if we get good progress and good outcomes there, we'll be able to transition to hopefully phase 1 clinical trials. Paul, did you want to add anything?
Sure, Darius. I think that covers it and sums it up pretty well. There's hope for sure that we can translate this this approach for gene therapy that is being applied to other disorders, in some cases successfully applied in terms of an approved therapy. And yet we still have a lot of work to do at the animal model stage to really understand how best to apply it for INAD and whether we can effectively apply it. So you will hear more at the research update tomorrow, a little bit from me, and I think a little bit from Drs. Kurian and Rahim as well, who have been working on this.
Yeah, so maybe I can add just a little bit of flavor to that also. Because I've worked with the Kurian and Rahim group, they actually have a really good animal model for early aggressive PLAN, for INAD basically. And that animal model has been published. What they've been able to do is much more completely understand the nature of the disease, both at the sort of microscope level and at the functional level and at the whole animal level. What can the animals do? How long do they live? What are their main problems? They've really done we would say a deep phenotyping. They've done a deep sort of discovery of that animal model in such a way to validate it as a tool to answer the question, does a gene therapy approach work, at least in a mouse? So one of the other challenges of PLAN, INAD, is that you have to get the whole brain, right? It's a whole brain disease. It's not just sitting in the place where iron accumulates. Every part of the brain is affected. And it's not even just the brain, it's also the spinal cord and the nerves. And so it's a big challenge to reach all of those tissues. However, having said that, the London group understood that challenge in going into this, has had some very good insights into how to enable that sort of broad delivery, that widespread delivery. And in that animal model, have been able to convince themselves and others that it's a really compelling approach for INAD. And so they'll talk, of course, in more detail tomorrow. They'll tell you a little bit about the sequence, because going from mice to humans is too big a jump. There needs to be some safety work in between, and they'll talk more about that. The real question I think that's being asked is, will it help my child today or soon? And that's a very hard question to answer, because I don't know how far they are. Are they 2 years from a trial? Are they 5 years? Are they 7 years? I don't know. And will delivering a gene therapy to a person who is well along in their PLAN, will that help that person? I don't think we know the answers to those questions. And there may be animal studies that help us know the answers to those questions, but I don't think we know the answers today. There are other neurodegenerative disorders that affect young children where we do know if you don't deliver the gene therapy early, or I should say, the earlier you deliver the gene therapy, the better the outcome, the more function the person has. They're not able to recover. So even though a cell might get the gene, it doesn't recover its function. So you don't want to think about it as a recovery approach, but rather as a no more disease going forward approach. And I think in PLAN, it may be something similar, where the earlier it can be delivered, the better. And that will, once we do have a gene therapy promising for humans, it will push the issue of needing to identify INAD, PLAN in the newborn period, really, so that we can treat it as early as possible.
Yeah, maybe I can follow up and add a little bit more to that from our perspective, because we've been doing some studies in a different animal model, looking at kind of starting treatment later, at a later age than, say, newborn. And unfortunately, we haven't seen great success, with that approach. And we haven't jumped to the conclusion that we just can't do it if we start later. We think there's much more to look at in terms of optimizing the delivery. And unfortunately, the delivery gets more challenging, at least in mice, as the mice age, but we think that may be the case for humans as well. And by delivery, I mean being able to get the gene, this replacement gene, everywhere. As Susan said, INAD's a huge challenge in that way, unfortunately, because we, to be effective, to be really effective, we want to deliver it everywhere in the brain and the spinal cord. We'd probably be satisfied with partial effectiveness, though. So I think we just need to, I think there's more work to do at the animal model stage to fully understand, how best to apply gene therapy. And yet there's reason to be hopeful.
We talked about this a little bit in the BPAN session, that it may be that that research developed to kind of address the treatment of all brain genetic disorders with sort of a plug and play kind of a system, where you put in the INAD gene or you put in the BPAN gene, you put in whatever you need. It may be that a system will be developed, whether it's gene therapy or a kind of CRISPR editing kind of approach, that a sort of a system for addressing or treating genetic disorders that affect the whole brain will be developed, and that we can sort of leverage that kind of work and apply it specifically to this this group of diseases.
Yeah, and I think there's promise on that front with spinal muscular atrophy. Certainly the FDA approval for that AAV9 mediated gene therapy. We're giving that to infants who are born, who are confirmed positive with spinal muscular atrophy, giving them an IV infusion. And that is able to deliver a functioning copy of the gene to the central nervous system. So that, I think, is a good starting point. It's an interesting model. Of course, a completely different disease, but it is a brain disease also to a large extent, of course, involving the spinal cord also. So I think that that's some promising data, and hopefully we can build on that.
Thank you. I'm going to call out one other question that came up in the chat related to this, which is there an anticipated time window for the use of this in INAD, for example, a maximum age? And I think Susan has already addressed that pretty clearly, saying that earlier is clearly better in our minds. As somebody involved in clinical trials, I can tell you that I think, they will develop inclusion and exclusion criteria when this actually goes to trial, whoever's model or multiple models. My guess is that could be age-based, or it could be more based on certain INAD milestones. For example, if they've reached certain symptoms or certain MRI findings, there are a number of different ways you could determine who would be included or excluded. And I think that's going to be a work in progress as we move forward. We had a follow-up question from our first one as well. And I'm sorry we didn't address juvenile PLAN as part of that in terms of who should be on the team and management. But this one is: my family member is a newly diagnosed child with atypical or juvenile PLAN. Are there different treatments or expectations in terms of interventions for symptoms or expectations that we should have, relative to INAD? And maybe you can take a first crack at that, Susan.
Is that in the context of gene therapy?
No, I think it's in the context of who should be on the team and just general management. What should we expect?
Okay.
How might it be different or the same?
Yeah, so INAD is a very consistent disorder, one to the next. And that is, if you take a room with 5 kids with INAD, they aren't identical in terms of their disease progression, but they're very, very, very similar to each other. After that, it's all different. Everybody's different and really quite different. And so what's true for one person with kind of a diagnosis of juvenile PLAN or even later, what's true for one person is not necessarily true for another. So things get much more complicated very, very quickly. I would say that, a child neurologist for the children, an adult neurologist for the adults, certainly I think a medical geneticist and genetic counselor serve a purpose on a maybe once a year basis. And then therapies that are specific to the person's needs. If they're having pulmonary problems, maybe a lung doctor. Vision is important for everybody in the PLAN spectrum, and so an ophthalmologist, a lot of attention to vision, as Jenny suggested, augmentative communications, or somebody who can assist with devices or alternative means of communicating. I think that those would be some of the important things that I would reference. Jenny, did you have other?
Yeah, I mean, I think sometimes a developmental specialist or even a physiatrist might kind of take the place of a neurologist or serve the same needs. So depend on your area and your hospital and who's best suited.
Yeah, I think that's a really good point, Jenny. What I've noticed in the natural history study, because we've had several relatively new juvenile people enroll lately, because they are slowly progressive and very functional. They're still in school, they're doing their thing, but they're doing it maybe with gait changes and falling risk and maybe a little bit of cognitive, they need extra support in school. So to me, I start seeing the physical therapists and the occupational therapists and the speech and the IEP and the support in school to be kind of their main team. They're not necessarily even on medications yet at that point. So it's definitely a different approach, especially in those school years or, grade school years?
I wouldn't mind adding something to this. So the only other specialist I find is very important in the adolescent years is an orthopedic surgeon. And that's because you want to ensure that the hip health is good. There's no scoliosis developing that could actually impact pulmonary function. So we get our orthopedics involved quite early to follow these kids so they don't suddenly have a severe scoliosis or a hip that's dislocated and the child is in pain but unable to tell you, so that these things are monitored and surveillanced.
Sunita, do you want to introduce yourself to the community?
Sure. I'm Sunita Venkateshwar, and I'm a child neurologist from Ottawa, and I see many patients with neurodegenerative diseases, including leukodystrophies and NBIAs. And I actually do follow some PLAN patients as well of different ages. So I just don't have the same volume as many of you, but I do have involvement with some families.
Thanks, Sunita. I'm going to move on to another question that was submitted a few weeks ago, and it's a good one. I think it affects a lot of people. How can we provide stimulation and foster interaction with our kids who are now immobile and somewhat locked in? I know, Jenny, you had some thoughts on that, and then maybe others can contribute.
Yeah, I think that's a really excellent question. That sometimes I've certainly seen kids who become more disabled in some ways, and that may lead to less participation. But really, we want to look at how can we maximize quality of life, engagement, participation for each child. And part of that relates to motor function. So even if there's loss of motor function, doesn't mean a child can't participate in activities or be around family members and friends and go to school. And having somebody who has experience with motor disability so that they can take a look and make sure that there aren't any contractures developing that might limit the ability to sit in a chair comfortably or be in a stander. And then communication. So even if children don't have verbal communication, it doesn't mean they're not understanding and don't have things they want to communicate. And there are augmentative communication experts. They're not plentiful, but they're out there. And children like this are the right children to see a communication specialist, because they may be able to communicate not with their voice, but with their eyes, for example, and we can use technology to help them do that. And that can just open up the world to them. So a big plug for augmentative communication. And, just kind of knowing what the child loves and enjoys, really trying to include that in their daily activities.
I might just add, and it's with the caveat that it's easy for me to have suggestions that complicate families' lives because I'm not having to live with them. But if you have a pet, encouraging sort of physical contact and just stimulation, taking your child, if they're able to be comfortably in a wheelchair, taking them into nature, having the wind on their face, the sounds, new sounds, having them at a playground where other kids might come up and ask some questions about them and maybe touch their hand, those kinds of things. I think really thinking openly and creatively about what your child can teach the world and what the world, beyond the sort of traditional ways that we interact, what the world can give to your child.
Thank you. I was thinking about this too, and I was remembering at least 2 families in the past who have been very big on specialized gentle swings. One had an outdoor swing, and I think one may have even had an indoor one. So that might be the new challenge at home. But I know you all talk about this in your private family sessions as well. I'm sure you have stories to swap about different things that you do. So this next question was another one that was pre-submitted. I'm going to direct it to Paul because this is more your area. The question is there a drug to reduce or slow degeneration?
Yeah, that's a question we care very much about in our research. Have really thought about all the different, I guess, avenues that we could pursue identifying such a drug or developing such a drug or another type of treatment other than traditional drugs. Right now, unfortunately, we don't know of such a drug. And nor is there any, I guess, good evidence for, another type of approach, in terms of how we can actually affect the disease course or the process of neurodegeneration that's underlying that gradual gradual decline and loss of abilities. So the simple answer is right now, we don't know of anything. I'm happy for other people to add perspective. When researchers think about this, we mentioned gene therapy, and certainly that's an approach that we really think perhaps provides ultimately the most hope to alter the course of the disease, maybe even reverse some of the effects of the disease if we're fortunate. And yet there are other approaches we think about in terms of avenues to develop a drug, and you'll hear about some of those tomorrow as well from the various researchers on the panel. And for us, we've thought about other ways that we could either help a protein, the PLA2G6 protein that has a mutation, a misspelling, a lot of times just one misspelling in the 800 amino acids that make up this protein. Could we help it function better? Could we do something in terms of a drug that works on other pathways and processes in the cell that would compensate? We've had hypotheses about whether, based on some of the I guess commonalities or overlap in terms of metabolism with other NBIA disorders like PCAN. We've been interested in whether the CoA pathway, and I know Susan has an interest in this as well, whether if we kind of can boost the CoA pathway, that could partially compensate for some of the effects when PLA2G6 is not functioning. And there are other ideas as well about how perhaps you can't really replace or replace the function of the protein or help it to function better, but maybe you can find ways to compensate for the fact that it's not functioning well.
Thanks, Paul. A couple things coming in through the chat. One of them, I can put on my genetic counselor hat and field. It's, if my child has INAD, will my second child with a change in PLA2G6 also have INAD, or will it manifest late? And the simple answer is no. I mean, within a family, this runs true. The reason is if you've had one child with INAD, then if you have a second affected child, that child is going to have the same exact 2 gene changes as your first child. That doesn't mean the background of all the other genes isn't important. It is, and we don't expect them to be identical. They are going to be different in all kinds of ways, but we would still expect them to have the infantile form. They're not going to have, juvenile or adult PLAN. It runs true within a family, and that's mainly related to the type of gene changes that they have. We also had a question. I know clinical trial is a hot topic here. I'm not sure we have an answer to this one either. Can a child with juvenile or atypical NAD be expected to participate in a gene therapy trial for INAD? Maybe Susan and Paul can at least give their perspectives on what they've heard or what they're thinking might happen with that.
Yeah, so I don't know is the true answer. I think it depends on the framework in which a gene therapy has been developed. If it's been developed with all of the focus being on INAD, early intervention, then I think probably not. But often what we see is the initial steps of gene therapy development focused on kind of the quote ideal situation for an intervention, for a treatment. And then sort of relaxing a bit or widening the circle of who can participate. It's a terrible analogy, but it's a little bit like vaccination, right? You start with the a certain group, and then you widen the circle of who gets vaccinated. Something like that might be reasonable, but I don't know, Paul, you may have something you want to add there.
Yeah, actually, I'm not sure I understood can you just repeat the question, Alice?
After I unmute myself, yeah. I mean, the heart of the question is, if my child has juvenile PLAN, will they be allowed to participate in a trial for INAD, a gene therapy trial?
Yeah, I think I agree with Susan. So I think, as Susan said, a lot of times, especially when we begin to design clinical trials, and I'm not someone who's an expert in designing clinical trials. Darius can weigh in on this as well. But we may think about how to design kind of a very focused clinical trial on a very homogeneous, similar patient group, so as not to kind of complicate the interpretation of how well it works and how safe it is. And yet, I certainly think in INAD and PLAN, it makes sense that if it works, that if we have something in preclinical studies before clinical trials in animal models that's working for INAD, or even, some of our mouse models maybe are more like a juvenile PLAN, I guess, phenotype or picture, then we certainly would have hope that it could be applied more broadly within the PLAN spectrum.
Yeah, I mean, I can add to that. I think one of the things we do when we're designing a clinical trial is to see how we can get robust data for the FDA, because at the end of the day, the FDA has to weigh in on the outcomes of your trial and if you did achieve your objectives. And so a lot of times the approach is to start with a sort of a focused group so that we can track them very closely. And so certainly, if we get good results from an infantile intervention, then it's likely that will be able to be expanded to other individuals. But if we have those good results early on, it's likely the FDA will approve it more quickly. And that's what we saw with the other, like the spinal muscular atrophy gene trial. There were really great results early on in the trial, and that really accelerated the approval. So, and of course that now could open up other options for other subgroups within that condition.
Thank you.
Allison, maybe it's a nice platform for you to talk about the natural history study, especially on the heels of the NIH talk on the importance, but just specifically for INAD Ready and how it really serves all of the hope for therapeutics that we're talking about.
Sure. So there will actually be, I think, Saturday morning, I have a 10-minute talk on this same subject, but not all of you may be up Saturday morning at 8 a.m. So I will give a shameless plug here as well without delving into all the details. But, coming off the talk by Dr. Sid, we do have a PLAN specific natural history study. It's called PLAN Ready. We're actually in our 4th year. So we have very good, long-term data now on a set of about 40-ish subjects who have been rolling in enrollment. So some of you have been in it, with me since the start, patiently chugging along with your every 3-month updates. But it's critical for the interventional trials that are coming. And I don't want to totally give away my talk for Saturday, so I'll probably just leave it at that. But what I will say is, Dr. Sid made a really interesting point to me. He said, if you're thinking about participating in a natural history study, think about yourself first. And, are you getting the care you need for your child? Are you all, is it just triage right now, or are you ready to move on and participate in a natural history study? And what we've seen specifically in the PLAN and INAD community is a little core who's really dedicated to participating, but then we wonder sometimes why we're not getting participation from the broader group. And there are people out there, I know that people are out there who are not participating in the natural history study. And Dr. Sid's point was really well taken for me that, maybe you are in triage mode right now. It's been a rough year. And on top of that, you have a child with INAD. And I know I know what you've got going on. So those of you, if you find yourselves at a point where you think you could take on a natural history study, we try to keep it as easy as possible for you. You can do it online. You can do it at 1 a.m. if that's when you have time. But I'm sorry if you're awake then. But it's available in a way that we try to make very easy and low requirement for you. So, and it has been very successful. We would really like to get our numbers up a little bit more, especially to support these gene therapy and small molecule therapies moving forward. So we're ready when we have an intervention and we can convince the FDA that we're good to go with those outcome measures. I don't know if Susan or anybody else wants to comment on that study or natural history in general.
The only addition is that it's really hard, almost impossible to get a federal grant for a natural history study. We put in, I think, 3 grants to try and get our natural history studies funded. And oftentimes the response is that's really something that the family advocacy community, we look to the family advocacy community to support. And so I wanted to call out INAD, the INAD Cure organization that has been a really great partner with us in this, and a strong supporter since the beginning, and a really very much valued partner, including going forward.
Absolutely. Thank you. There was one other question coming in from the chat that I think we can address. I know about the Retrotope clinical trial and their RT001 compound. Are there other trials or medications that would help? And maybe Susan, I can ask you to start with that. I think you're on mute. Yeah.
That's because I'm chatting with somebody while I didn't look at clinicaltrials.gov this morning. And I don't mean to make that as a joke. Things are changing all the time. And as plugged in as we all are, we don't know everything that's going on. There was a brief trial with a very limited enrollment of a compound, disipramine, in INAD, based on some fruit fly work that I think Hugo and Guang will be talking about tomorrow at the research session. But I think that trial is closed. I'm not aware of any other imminent interventional trials, and we'll hear more from the London group tomorrow about the status of their gene therapy work.
Thank you. Would anybody else want to add anything about past trials, future trials? No. Okay. There was one other question that just came in that's an interesting one, because I have seen a few families doing this. I think maybe Paul could start us off on this, because you understand how the pathways intersect. Do you know anything about the positive effect of calcium pantothenate? Should they be taking calcium pantothenate if they have PLAN?
I can weigh in, but maybe Susan can too. And so we've been interested, I mentioned, in how the pathways may intersect. And pantothenate is vitamin B5, and that is kind of the starting point for synthesis of CoA, coenzyme A, which is important for a lot of lipid metabolism, a lot of metabolism of fats. And PLA2G6, the protein affected in INAD, is involved in lipid metabolism in a way where we think that downstream of what PLA2G6 does, you need CoA, and that if you had more CoA, you could help compensate. And this is a hypothesis. We have a little bit of evidence, in animal models supporting it, but not great evidence. So I really think it's just a hypothesis at this point, and not something where we can give strong advice about what you should be doing now. As far as pantothenate goes, I think Susan can comment on this. We're not convinced, and may actually think that it's not the case that taking more pantothenate would help produce more CoA.
Yeah. Calcium pantothenate or vitamin B5 is cheap. You can buy it at the grocery store. and it's water soluble. It's one of the water soluble vitamins. And so if you eat a bucket load of it, you just pee out a bucket load of it, whatever your body doesn't need. So your body has a pretty good regulatory system for only taking up what it needs. And so taking more in INAD, would that, even if driving CoA levels up, the Kotzbauer hypothesis, even if that does pan out, is that a way to get your CoA up? I'm guessing probably not. If your body, if your body is getting enough, and if you're eating either an average American diet or average anywhere diet, or on a supplement, a feeding, a G-tube kind of feeding, those have sufficient vitamin and nutrients, including vitamin B5. I do think the hypothesis is Paul's idea. I think Paul's idea is an intriguing one, and there may be other ways to test it, including possibly with, with the therapeutic that is being tested for safety in humans right now, the 4-phosphopantothene therapeutic, or what we call CoAZ. And I think the experiment to be done there might be, and we've talked with the London group about this, actually trying CoAZ in a mouse model. In a mouse model of INAD. The Baylor group, Hugo and Guang, they have fruit flies with INAD. And when they tried CoAZ, our compound in the fruit flies, it didn't seem to help the flies. Now, whether fruit flies are a long way from humans, so are mice, but they've got a whole lot more common biology. Is it worth doing the mouse experiment? Maybe. We don't know. We won't know unless we do it. Mice are expensive to keep. They actually are quite expensive. We spend $1,000 to $2,000 a month every month taking care of and keeping up our mouse colony. And so it's kind of an expensive experiment to do. And yeah, I mean, the community of scientists and funders need to decide whether it's worth doing.
Thank you. There's a question coming in from Katie on the chat that I think I can start with, and maybe anyone else can chime in. There's been a lot of discussion in our support group if their child has INAD or ANAD, so infantile onset or juvenile onset. Is the diagnosis based on the starting age of regression and or the actual gene mutation? So I don't think we're quite good enough yet to just look at the gene mutations with no other information and say that one's INAD and that one's ANAD. And part of that reason is some of these mutations, while we can predict what they do and if they're more or less severe, some people get one of each. They get one kind of severe mutation and one more mild one. And then we're like, I don't want to be the one to try to predict what's going to happen there. It's probably somewhere in the middle. Susan made a very good point. The infantile cases, the early onset, sort of more rapidly progressive cases, they're pretty homogeneous sort of over here. But then beyond that, there's a really broad spectrum. And I think those of you who have been told your children have atypical or juvenile disease have experienced that spectrum, where some have onset at age 4, but some don't have onset until age 10, and things happen at different rates. So, as sort of a hard stop, I think for our natural history study, we've said if you have onset of any symptom before age 3, we're going to call you infantile. But you have to acknowledge that there is this spectrum and that this isn't exact or precise. And that unfortunately, we're not at a point where we can predict right now just based on the gene. Do you want to add anything to that, Susan?
Yeah, I'm writing it in the chat. I think for every rule that we set of what's INAD and what's ANAD, a child will tell us that we're wrong, and appropriately so. A child will teach us that we're wrong. So we're not, yeah, I mean, we can usually answer the question about an individual child who's sitting in front of us and we're able to examine, looking at the genetic data, looking at the human there in front of us and how they've gone, how their disease has gone over time. We can usually give you a pretty confident answer, but to sort of make a rule, again, the kids keep proving us wrong.
Yeah, well, I think too, a lot of what drives parents to ask that question is they're looking for the crystal ball. They want the right label so they can predict what's going to happen in the future. And honestly, if you try to just acknowledge that even with the right label, we're not going to be able to do that. Sometimes that can sort of free you from getting too hung up on these labels. We see the same thing with PCAN, honestly. And it's not, in my opinion, really useful to get too hung up on the label, but more to just look at your child. You know, Susan always says your child's going to be on their own personal curve for this, and usually how they've been doing is the best predictor of how they're going to keep doing. I see a couple more questions coming in, but we also had one that was pre-submitted that I'll go to. And this is a tough one. I think this is directed more at adults. So maybe those more advanced INAD patients or atypical or even adult onset patients. How do we get better services and financial support for individuals with PLAN, especially adults? Where do we go to find them? I run into lack of care due to people not knowing about this disease. So I think any of our panelists can address this. Maybe I can ask Jenny to start from a child neurology perspective in terms of sort of accessing support and getting the right services.
And Jenny may be talking about transition.
Yeah, I think this is an issue for lots of kids with developmental disabilities. And sometimes it's helpful to look at kind of broader categories of disabilities and see what resources are out there. So for example, the cerebral palsy community has a lot of similar needs to kids with PLAN. And a lot of similar resources. And so sometimes I'll direct families to the United Cerebral Palsy Foundation website to look at transition resources or resources for support, financial or otherwise there. And yeah, thinking about transition early, age 12, I think is usually the recommendation. Start planning ahead and so that the pediatricians can help map out what transition looks like into adulthood. But it can be, I think, a real challenge to find the right resources as adults.
Okay, that brings us to the end of the questions that people submitted ahead of time, and I don't see a whole lot of action going on in the chat. Tell me, anybody, if I've missed something, but I think for those of you who are participants, this is sort of your chance to submit additional questions and have access to all these wonderful clinicians. Not much else going on here. Okay. Well, Erica, I'm not sure if you want to take over here and wrap us up or maybe try to encourage some more questions.
Yeah, I'd say really don't be shy. I don't know if anyone may feel intimidated or worried that it's a stupid question. Everybody here is very friendly, very used to answering questions from all sorts of different people. So honestly, lay it out here. This is your chance.
All right. Well, while we're waiting, I'm going to ask Darius. I think I saw a bobblehead to your right. Is that something you can hold up for us? Because I am intrigued. Is that you? Nice.
Oh, here, let me unmute. Yeah,
Thank you.
my staff got me a bobblehead. So I think you can go to custom, I don't want to advertise for them, but I guess if you want your own bobblehead, you send them a picture and then they make it.
That's a pretty good rendition. I like it.
Yeah, like it. Is that close? No.
It's good. All right. And in the interim, we have had one more question roll in here. Okay, so I think this is deferiprone. Have you heard much about deferiprone or Feriprox? So what do we think about chelation for PLAN? Susan and Darius, maybe you can start us off on that. Should it be pursued? Is it worthwhile?
Yeah, I can start us off and then Paul also may have some opinions because the opinions, my opinion at least, is derived from what we know about the PLAN protein, what it does, what we think it does, how it connects to iron, what we know and don't know about how it connects to iron accumulation. So iron accumulates in lots and lots and lots of neurodegenerative disorders, the NBIAs, but it also accumulates in Parkinson's disease, in Alzheimer's disease, in multiple sclerosis, and in lots of others. And the question is always asked, first of all, what is the link to iron, and should we be trying to get the iron out of there or keep the iron from accumulating? And part of my group's focus on identifying the genes for these disorders is so that we can know the precise problem, the precise primary problem in these disorders. We know iron accumulates, but what's really causing the disease and the iron accumulation? In finding those causes, sometimes we can link it to why the iron accumulates, but not always, but what we pretty much know in these disorders is that there's other stuff going on over and above the iron accumulation. And while removing iron or preventing its accumulation may help to some extent in some of the NBIA disorders, we haven't tested it in most of them, it isn't going to solve the disease problem. So it may be making things a little worse. Taking it out might, or keeping it from accumulating might make things a little better, but there will still be, I believe, a very significant disease process aside from the iron. And so our focus in all the work that we do, we could have spent our life working on iron, but we have focused on why the iron accumulates, what the upstream problem is, and trying to fix the upstream problem. And actually that idea has borne really quite a lot of fruit in Pecan, in the sense that Dr. Jiang, who is here, Su-Young Jiang, Sue is really runs the NBI laboratory at OHSU, and she discovered that if you fix the primary Pecan problem, the iron problem fixes itself. And that was really kind of the most impactful data set that we have that kind of reaffirms this idea that iron is a downstream problem. And if you fix the upstream problem, you likely are going to be able to resolve the iron problem. And so, long-winded answer to, we don't encourage people to use a chelating agent, a sponge for taking iron and making it something your body can get rid of. We don't advocate for it. We don't advocate against it. We kind of walk this line of supporting families. We tell them what we know, and then we support them to do what they want to do. Yeah.
Yeah, I mean, I would agree with that. I think it's, could be also challenging when you talk about chelation to, for something that is an intracellular process. Of course, you could probably impact ion balance by lowering it in the blood, and potentially lowering it intracellularly. But again, iron is also essential. And of course, you don't want to deal with potential side effects by lowering it too much. So again, it's I completely agree that it really wouldn't be addressing the issue directly.
Yeah, and I would say I agree as well, that just based on what we know about the PLA2G6 enzyme and INAD or PLAN, we don't know that iron plays a central role as being part of the problem. We don't even know that it is part of the problem. And if so, it's probably a small part of the problem, coming kind of, as Susan said, downstream or maybe several steps removed from the primary problem. So just don't really, have enough evidence based on our current understanding to, to say that that's likely to be helpful.
Thank you. And there is a follow-up coming in that I know Susan will have an opinion on. And there is no stupid question. It's is iron accumulation from the food we eat, like spinach, I guess, can you comment on why the iron is selectively going into the brain and whether this is related to our overall iron metabolism and the foods that we're eating, or if anyone needs to be concerned about that?
Sure. In the NBIA disorders, as best we know today, your brain, the person's brain with NBIA will take up as much iron as it needs, or as it thinks it needs. And so if we limit iron in the diet, we will only cause iron deficiency problems like anemia and other problems with organ function. So it is a bad thing to limit iron in the diet or iron supplementation. We would treat somebody with an NBIA disorder who is iron deficient in their bloodstream. We would treat them just like we do a person who doesn't have an NBIA disorder. I think that's important because there are quite serious side effects, quite serious effects in particularly the bone marrow and the blood circulation to not have sufficient iron. I forgot. So what was the beginning part of the question? I sort of answered it.
Do they need to be worried about foods, diet, limiting iron?
Oh yeah. So no. In fact, they should be on a healthy diet with sufficient iron. And if their iron stores are low, they should bump them up, ideally through diet or iron supplements. The idea that there's too much iron in the brain is a really interesting one. And what it's turned out to be, so in many of the NBIA disorders, we don't really quite understand the link, but we now understand the link in PCAN. I believe we understand the link. And it turns out PCAN is kind of like some other disorders where iron is not managed properly, in the sense that the reason iron accumulates is that the cell thinks there isn't enough iron. And the cell thinks that because the form of the iron that is in the cell and is abundant in the cell isn't detectable. Like the cell can't tell that it has enough iron because it's not in a form that the cell can use. So it's like there's plenty of it around, but it's not, we say, bioavailable. It's not available for use by the system. And so the cell thinks, I don't have enough iron, send me more. And it keeps signaling to send more and more. And so there's iron accumulation, but the cells detect low iron. And so it's kind of it's a mixed up system. It's an out of sync system. And so it's an iron accumulation system, but it's also kind of an iron insufficiency. So I wanted to just make that point as well.
Thank you. There's a question in the chat from Erica, just to support everybody. For people who don't have direct resources or access, is there a website or database for them? Yes. If you've made your way to this meeting, I think you've found the NBIA Disorders Association, which is a great starting point. Their website has information. I'm biased, but I like our website. That's NBIA Cure. We've got stuff there about the different forms of PLAN. And we also, I'll point out, have a button that your clinicians can use where they can ask for a consult from our clinicians. So sometimes talking doctor to doctor, if there's a specific challenge or something going on, and most of you know, your child is the only child with PLAN that your doctor treats. So if our experience can be helpful to them, they can certainly reach out to us in that way. And INAD Cure has a really nice website as well with information and different types of resources there. Then we've got a couple questions rolling in about the retrotope compound, including might there be trials in Europe, and is there any assessment available about how effective it may or may not be? Darius, is it fair for me to direct those to you? I don't know how much you can really tell us.
Sure. So the trial is still ongoing. We're collecting data. The company will be presenting data to the FDA shortly. There was just a data lock that I participated in. So we were in a mad rush to get all of our data points in, so that can be looked at by the FDA. And so we're hoping that in the not too distant future, within the next few months, that we'll be able to get some feedback from the FDA. And that's pretty much all I have for you at the moment.
Thank you. We had a question from Matt. We've noticed a lot more adult onset PLAN in the Facebook group. Is that a trend you've noticed as well? Is there a reason behind it? It is absolutely a trend I've noticed as well, because I'm also in that Facebook group, but in the natural history study as well. You know, I keep trying to drum up more infantile cases because we need a certain number for statistical significance, and I keep getting more of the juvenile cases, which we need as well. I believe me, you are equally important. It's just really interesting to me that they've been rolling in more frequently lately. I don't have a good answer for you other than I think we must be getting better at diagnosing it. And maybe, you know, the between exome and people's bar for doing exome sort of coming down, people doing it more liberally, that we've just been able to identify some of these adult and, you know, more grade school to junior high age kids a little bit sooner. I don't know if anybody else wants to chime in on that. Okay. And then
Hold
Susan,
on, I did want to just
yeah.
say that I think diagnostics is, you know, has advanced so much, and it's being introduced, being sort of non-biased genome or exome testing is being done more readily in both young children and in adults who have really gone without a diagnosis for so long. So I think it's really that the diagnostic capabilities and that neurologists are learning that full spectrum. Yeah.
For sure. Thanks, Erica, for putting our websites in the chat. So those websites I mentioned are there now if anybody needs a link. And then Susan, I'm going to direct this one to you. Can the probable cure for PCAN help in the research for the cure of PLAN?
Yeah, so I don't think that that's so I don't know what the probable cure for PCAN is yet. And I want to be really clear that there is today, nobody knows a probable cure for PCAN. We have a lot of hope, but I think that that's an ambitious statement that I wouldn't be comfortable making. Having said that, I think that it's true, particularly for PCAN, PLAN, MEPAN, and COPAN. I think that they're sort of cousins or sisters, or I think that they're close relative kind of diseases. And what we learn from the biology of one and what we learn about the treatment of one will help us in thinking about others, and possibly we'll actually have a therapy for one that actually does look like it works very well may have a role in treating some of the other ones. And so that's something that we're paying very close attention to. That's one of the reasons why, you know, we don't want the INAD community to go off and separate entirely from the NBIA community. I am absolutely convinced that we are much stronger together, and not just because we're bigger, but because we actually need to learn from each other.
Thank you. There's another question in the chat from Lena. CRISPR was brought up earlier. Any idea if it's a therapeutic being researched for other NBIA diseases? Any thoughts on translation to humans affected by neurologic diseases? Can I ask either Susan or Darius to first give us the 60-second what is CRISPR, so everybody's on the same page before we delve into that?
Sure, I could jump in. So CRISPR is just, I guess, more simply is a way to go in and alter potentially individual nucleotides. So if there's a point mutation, the CRISPR-Cas9 system could theoretically be utilized to go in and flip almost a variant within a gene, thereby allowing for normal production of a gene. CRISPR is probably more effective in doing certain things. It certainly was originally evolved as a bacterial immune system, if you will. So its design is to actually cut things out or cut things up. And so really we're trying to co-opt that evolutionary design to do different things. And so it's definitely an active area of research. There's a lot of progress being made, definitely used quite a bit in basic science, making knockout models for disease. It's been very successful in that realm. There's still some reservations about CRISPR just in regards to possible off-target effects. So, for example, is that one spot we're targeting in the gene the only spot that's going to be affected? I think we're getting more and more data, and I think we're getting better and better at it as time goes on. Whether we're at the point today to pull the trigger and go into at least in vivo gene therapy using that system, I don't know we're quite there yet. There is some work being done in ex vivo, and just to clarify, ex vivo is when you take cells out of the body, do something to them like gene therapy, and then put them back in. And in that case, it's helpful because you can at least look at the cells and make sure maybe nothing too strange is going on, versus in vivo, where you're infusing that system into the body, and it could really go to all sorts of places and cause impact. So you can certainly be much more targeted with the ex vivo approach. So all that to say is that seems to be a bit farther off than some of the current FDA-approved gene therapies that essentially just provide a functioning copy of the gene. It's kind of a bit more of a straightforward thing. Let's give a functioning copy and see if that works.
Thank you. Anybody else want to add anything to that? Okay. I don't see any more questions coming in. This is sort of last call. It's been kind of quiet on here for the last 8 minutes or so. So I'm guessing maybe we're getting close, Erica, to wrapping up. Oh, there's a new one.
Yeah.
Let's see. A lot of the people, you're right, Matt. A lot of the people with the atypical kids are here and listening. The question is, my son has been diagnosed with atypical INAD at age 14. He had signs at 4. Would he be considered juvenile? According to our standards, yes, right? I said age 3 was sort of the cutoff we've been using. That's a pretty simplistic cutoff. Why do all his clinical tests, like his lab work, his MRI, his EEG, come back normal? Muscle biopsy and genetic testing was abnormal. What are your thoughts? Susan, maybe I can ask you to start with that.
Sure. That's juvenile PLAN. Basically, unless you can go in and do direct testing on the brain, inside the brain, which we don't do, you won't see changes unless you look at the INAD/PLAN places. So if there was a nerve biopsy, for example, they might have seen the typical changes that are seen. You're stating that the muscle biopsy was abnormal, but it doesn't surprise me at all that the lab work and even the MRI, I would have thought that there might be some changes, maybe some signs of, we say volume loss or some signs of atrophy, but maybe not. Those may come in time. I was asked kind of offline, does everybody with PLAN have iron accumulation? And I believe the answer is eventually yes. But every time I say something like that, a kid proves me wrong. And then I see, Charity, you've clarified MRI did show volume loss at age 14. Volume loss means, the skull is the same size, but the brain has gotten a bit smaller, and it gets smaller because some of the cells are dying and they're sort of it's called atrophy, you're losing cells. That is very common in PLAN, and it's sort of a whole brain phenomenon, maybe a little bit more prominent in the back cerebellum area, but not necessarily in the later forms of PLAN. That is what we see. What you're describing is PLAN.
All right, Erica has reminded us in the chat that there are no stupid questions. Last call. Okay, from Raymond. Why do narcotics during operations increase decline of function? Now, this is interesting. We just were sort of made aware recently that some families have had an experience where they think that anesthesia may have prompted some sort of decline. It's a question that we're planning to add to the natural history study once we understand a little better what to ask. So I don't think it's necessarily narcotics. Is that right, Susan? I can't remember from Manju what the concern was specifically.
Yeah, I don't think we know, because anesthesia, somebody going into a surgery usually means that they're on a more than one medication to enable the surgery. And so I don't think we have any confidence in being able to piece it together any more than that. I wondered actually if Jenny had any insights, even though this is a new phenomenon where and this is a great example of why our tight connection with the community and your asking questions is so important. I've noticed this thing in my child, and then let us ask others, is that a common thing? And then we learn something about PLAN that we never would have known if you hadn't put in front of us. But I don't know, Jenny, do you have any thoughts on that, or any examples of other disorders?
I mean, I've certainly seen kids with a variety of disorders where it seems like anesthesia kind of triggers some change with them. I don't know that I have further insights beyond that. And sometimes I see it for better or for worse. So I just had a kid who has epilepsy, and after getting anesthesia, seizure-free for 6 months. But I've also heard this from other families where they had some sedated procedure and there was a decline afterwards, but I don't necessarily have a good reason for it. Maybe Sunita has some more.
Yeah, I mean, I think I have similar experience to Jenny. So there are a variety of conditions, and there's some that we know that the stress response induced by the surgery itself or the anesthesia or both can actually cause a problem. So there's certain disorders where we know that that is the problem, that there's a stress function disorder. And then there's some groups of conditions like mitochondrial disorders, I'm using the grab bag, where we know that in certain times you don't want to put a child through multiple anesthetics. But in general, I don't think you can make a generalization for this disorder or for any of them, because there are some other intricacies to it. But same as Jenny, I mean, a lot of patients do fine with anesthesias, but we have to be aware that I think what we do is each time we think of putting a child under anesthesia for something, we really need to see whether it is necessary to go through for that particular procedure, because even in a child who doesn't have a developmental issue, we have to think twice putting a GA on a child.
Thanks, Sunita. The other thing I've wondered with this question is, they're having the surgery for a reason. Usually they're having a G-tube placed, they're having a baclofen pump. So to me, that means there's regression clearly going on that's being addressed with surgery. So I'm wondering if it truly is the anesthesia, if it's something that would have happened anyway. I mean, you have to do a controlled study to answer that question, right? But, couple more questions popping in. People are feeling their chances slipping away here. We've got about 15 minutes left. Do you think exercise, environmental stimulation, and daily routines can help play a part in slowing the regression? Maybe Sunita, can I ask you to address that one first? Kids you've seen?
Sure, I think yes. And I do like the link that was placed, that Jenny placed earlier from McMaster University. If you look higher up in the chat, because that goes through the five or six different things that you should be thinking about with your child. So yes, I think all of this is important, especially in a child who may not have the ability to initiate these things themselves. Incorporating these activities, whether it's exercise or play with friends or any type of stimulation, will be beneficial, both for like mental well-being as well as for physical well-being. Will it slow the regression? I don't think we can say it can't say that for certain. I mean, it might mean the type of exercise you're getting may help because it may go along with the physiotherapy that's already undergoing or the occupational therapy that's happening. So yes, in that sense, it might be almost an adjunctive thing you're doing. But overall, you cannot tell exactly. I don't think that's easy to tease out in terms of slowing the regression, but it'll definitely help with maintaining overall wellness and nutrition and all of that stuff that we think of. I think it'll just keep your child as healthy as possible overall.
Well, and then along that same vein, there's another question, wondering whether any, sort of non-traditional, natural or other, supplements, et cetera, are reported to have some improvement. I mean, specifically in PLAN, I can tell you, I don't think anything is reported. Tell me if I'm wrong, panel. But, well, I'll take that back, Susan. Maybe you can talk about fish oil and what we recommend there. Anyone else want to make any suggestions on this?
Yeah, so the fish oil recommendation is to take the amount that is recommended by the Food and Drug Administration. It's the age or weight specific recommended daily allowance. You can overdo it with fish oil. And so we don't recommend a marked increase in dose, maybe a little bit increase. And it's a hypothetical. It's one of these things where we're taking it is very, very low risk, and it may have some benefit. In some of the laboratory experiments, there was some evidence that that kind of oil, that kind of fat was had some benefits, but whether it actually does in people with PLAN, we don't know. There hasn't been a clinical trial to test that.
Okay. I don't see anything else coming in. Erica, maybe I can ask you to sort of wrap us up and send us out.
Okay. Yeah. Oh, okay. Well, every time we do this, a couple more. One more that came up.
Taurine, there's a question about taurine. I'm not sure who on our panel might be best to respond to that one. Does anybody want to volunteer anything with supplementing taurine? Maybe it's an unknown to all of us.
Yeah, I mean, you could probably find some paper somewhere advocating for all sorts of things, but yeah, I haven't seen any evidence that has made me excited or strongly opposed to, one of the sort of kind of frameworks that we've taken very early on is to work with families who want to try things. They want to try a new kind of supplement. Is sometimes they'll send me the list of ingredients. I've got plenty of work, so don't everybody jump on that. And I'll look through the list of ingredients, see if I think it's safe. If I think it's safe, I'll tell them to go slowly and try it. But we try to be supportive as you and your families want to try things without being totally discouraging. There's no proof of that. Don't even bother. Because it's important for families to feel like they have some support if they want to ask questions. The most important thing from my perspective is that you're not doing harm. And there have been supplements in pecan. There was some individuals put on a supplement that the doctor who was working with them felt that those supplements made things worse. They were specifically selenium and coenzyme Q, and they were done together. So two things at once is never a good idea in a rare disease. They were started together. These were adults with pecan. They got worse over a couple of weeks. The doctor stopped these two compounds and they got better. I think they got better entirely back to their baseline. But was it these compounds? We don't know. But there's no compelling reason to take those from what we understand about pecan. And so that would be an example of when I would discourage taking something like that. But generally, we try to be supportive if it's not going to do harm.
Okay, and then we've got a couple last ones rolling in now. Jenny, I'm going to ask you to answer this one because I've seen you do it well before in other sessions. Somebody's still, wanting to know how when it's the right time for a G-tube.
Yeah, I think it's always a difficult question for families. And I think we did talk about this in other sessions that oftentimes I think families are more likely to do it later and wish they had done it sooner. And in general, the things that really kind of make me want to move forward with that G-tube are: one, a child isn't able to maintain their weight gain like they should be. Two, they're not able to stay hydrated. Three, they can't eat safely. So they're, aspirating sometimes, they're developing respiratory infections. Or four, I don't know, am I on four? It's just taking excessively amounts of time or energy to try to get those oral feeds in. And it's just detracting from quality of life and enjoyment. If any of those things are happening, it may be the right time to move forward with that G-tube. And just to remember that if a child is able to safely eat, putting a G-tube in doesn't mean they can't eat anymore. It just takes some of the stress off of a family from having to maintain their hydration and nutrition status orally, and sometimes can actually help keep kids out of the hospital, because if they get a cold and suddenly they aren't getting enough in, this way you can keep them at home and provide that nutrition and hydration.
Thanks, Jenny. I'm going to ask you to address this last one too. Put on your developmental hat that you wear all the time. Is there any problem with practicing core words with the idea of maintaining muscle memory, i.e. keeping the speech pathway active? I'm hoping you know more about that, what that question means, than I do.
Really know the answer to that. I think they're using language and practicing with communication is important, and it doesn't have to be specific words, at least to my knowledge. So, for example, kids who are learning to speak verbally, working on communication with signs actually encourages their other areas of communication. So kind of all these communication avenues support each other. So I don't know how to answer this, and I don't have the right answer, but I would say that an environment that's enriched with communication is probably going to continue to reinforce those language pathways. But there may be a speech therapist who can directly answer this better.
Thank you. And with that, I'm really going to ask Erica to wrap us up and send us out.
Thank you all so much. This was excellent, incredibly informative. Thank you everyone for asking the questions. This was really a wonderful session, and I'm sure if any one of you in the audience would like to follow up with any of our panelists, I'm sure they'd be happy to answer questions offline as well. So I am officially wrapping this up. Thank you everyone for all that you've done.
Thank you.
Good to see everybody. Thank you.